come to the topic. Sports injury. Today's topic is sports injury. Sports injury mainly occur in what parts? Namely, these are knee, abdomen, ankle, foot, hand. What are the injuries? In knee, anterior cruciate ligament injury and posterior cruciate ligament injury, snapping knee syndrome, collateral ligament injury, meniscal injury. In the abdomen, there is one injury, athletic pubelgia. In ankle ligament deformity, Achilles tendon, tendonitis, tendon rupture. In the foot, hemato, hand, gamekeepers, skiers thumb. Mallet's finger, also known as basketball fingers, jersey finger. This is the classification of sports injury. In the knee, anterior cruciate ligament and posterior cruciate ligament injury, snapping knee syndrome, collateral ligament injury, meniscal injury. In abdomen, athletic pubelgia. In ankle ligament deformity, Achilles tendonitis, tendon rupture. Foot, hemato. In hand, gamekeepers and skiers thumb, mallet finger, also known as basketball finger injury, and jersey finger. Now we will take knee section first. In knee, first injury is anterior cruciate ligament versus posterior cruciate ligament. What is this ligament? What are the ligaments? Anterior cruciate ligament, posterior cruciate ligament. At the knee joint. These are present at the knee joint. joint. Now we will see the image related to this. This is the image of lateral meniscus, medial meniscus. Okay, see, this is lateral meniscus, this is medial meniscus, and posterior cruciate ligament and anterior cruciate ligament present here. Okay, so what are the differences in anterior cruciate ligament and posterior cruciate ligament? Anterior cruciate ligament, posterior cruciate ligament. These both are intracapsular and extrasynovial structure. Both are intracapsular and extrasynovial structure. Both are intracapsular and extrasynovial structure. Now anterior cruciate ligament, major stabilizer of knee. By mechanism, how it stabilizes the knee joint. Mechanism: stabilizes by internal rotation and extension of tibia on femur. By stabilized by internal rotation and extension of tibia on femur. Okay, फंक्शन देखें तो function of anterior cruciate ligament: limit forward gliding of tibia on femur. Limits forward gliding. Mark the point. Forward gliding. Forward gliding of tibia on femur, and also checks hyperextension and significant contribution into lateral stability. Okay, significantly contribute in the lateral stability of knee joint. Limit anterolateral rotation of tibia on femur. Most important for walking downhill. most important for walking downhill. Okay. Now come to posterior one, posterior cruciate ligament. Its functions are as follows. Function limits backward glide of tibia on femur, and also checks hyperextension. Restrict external rotation, active in all knee movements. It participates in all the knee movements. In all knee movements. Okay. And most important for downhill, most important for uphill, walking uphill, most important for walking uphill, for walking uphill. Okay. Now look at the test which test their function normality, normal action, by which we can diagnose. Tests for anterior cruciate ligament are teeth mnemonic, flexion, rotation, drawer test. Latchman test, anterior drawer test, pivot shift test, and one newly recently added is Lely's test. New, recently added. Question may be asked on, examiner may be asked on Lely's test. Flexion rotation drawer test, Lexman test. Best of all, and flexion rotation drawer test is second best after Lexman test. In sensitivity and specificity. For posterior cruciate ligament functioning, we have test. For this test I also have mnemonic P Q R. Simple. PQR. P for posterior tibial sag. And posterior drawer test. For Q, quadriceps active test. For R, reverse pivot shift test. So we completed anterior cruciate ligament and posterior cruciate ligament in this section. So ACL and PCL. ACL both are intracapsular and extrasynovial structures. Major stabilizer of knee. ACL anterior cruciate ligament is major stabilizer of knee. Okay, mechanism by which it stabilized by internal rotation and extension of tibia on femur. Function limits forward gliding on tibia on femur, limits hyperextension, significant contribution into lateral stability, limits anterolateral rotation of tibia on femur. Most important for walking downhill. Okay, test for its functioning: flexion rotation drawer test, Leishman test, anterior drawer test, pivot shift test, release test. And for posterior cruciate ligament, its function are limits backward glide of tibia on femur and checks hyperextension, restrict external rotation, active in all knee movement, most important for walking uphill. Test for this posterior cruciate ligament are PQR mnemonic, posterior tibial sag, posterior drawer test. For Q, quadriceps active test, reverse pivot shift test. Now treatment for pathology in these ligaments: arthroscopy, reconstruction, arthroscopy, reconstruction. Okay, in this section we completed one deformity. Now come to our next deformity of knee is snapping knee syndrome. In this, tendon at posteromedial corner of the knee mainly involved. It occurs due to sudden extension of knee from flexion to extension. Okay, sudden movement of knee from flexion to extension. Most common tendon involved is tendon of pes and Serinus. Okay, this completes our second pathology, deformity, snapping knee syndrome. Now third one, collateral ligament injury. This is our second pathology of knee joint. Mechanism: of collateral ligament, abduction, flexion and internal rotation on tibia. It causes, collateral ligament causes abduction, flexion and internal rotation on tibia. A well-known triad for this collateral ligament injury is unhappy triad of O'Donoghue. Unhappy triad of O'Donoghue triad. In this, three parts of a knee joint are involved. These are: first to involve is medial collateral ligament, then anterior collateral ligament, medial collateral ligament followed by anterior collateral ligament, okay, and medial meniscus. This is most important of all. Question may be asked on this. O'Donoghue triad, unhappy triad of O'Donoghue triad. Now, second one, third. Now we completed three deformity. Next one, fourth one is meniscal injury. Meniscal part, you can see in this. Look at lateral meniscus and medial meniscus. These are the part: lateral meniscus, medial meniscus. Okay. For this, we can write differences between these lateral meniscus and medial meniscus, or lateral meniscus, medial meniscus. Lateral meniscus is semicircular in shape. Semicircular in shape. Semicircular. Medial meniscus semilunar smaller diameter meter but wider in body. Here opposite, larger diameter but narrower body. Here anterior horn and posterior horn uniform in size. Here posterior horn greater than anterior horn. Next point, entire periphery of meniscus not attached to joint capsule. Here entire periphery participates in making joint capsule. Participates in joint capsule. Not attached to lateral collateral ligament. Lateral collateral ligament, LCL, lateral collateral ligament, but it is attached to medial collateral ligament. Okay, more mobile, less mobile, less prone to injury, because it is mobile, more prone to injury. Okay, now once we revise, lateral meniscus semicircular in shape, smaller diameter but wider in body. Medial meniscus semilunar in shape, larger diameter but narrower body. Lateral meniscus anterior horn and posterior horn uniform in size, and in medial meniscus posterior horn greater than anterior horn. Entire dipara, posterior horn greater than anterior horn. Entire periphery, in lateral meniscus, entire periphery of meniscus not attached to the joint capsule. Okay, look at this gap. But in medial meniscus, entire periphery participates in joint capsule, not attached to lateral collateral ligament. Okay, medial collateral ligament, it is attached to medial collateral ligament. More mobile, less prone to injury lateral meniscus, more prone to injury medial meniscus. Okay, this we complete. Difference between lateral meniscus and medial meniscus. Meniscal tissue consists of 70% collagen, Here, type 1 collision are in more quantity than type 2. Note. Important note. Twisting force in a weight bearing flexed knee is the commonest mode of meniscal injury. Medial meniscus is more frequently torn than lateral meniscus. Injury to meniscus like bucket handle tear, bucket handle tear, more commonly found in young adult. Commonest type of medial meniscus injury. Medial meniscus injury complete in nature. Now come to the locking mechanism of knee joint. It may be physiological or pathological. Physiological, pathological. Physiological caused by quadriceps femoris. Okay. In this last 30 degree of extension, when femur rotates medially over stabilized tibia. It is physiological. In physiological, it is caused by quadriceps femoris. In this last 30 degree of extension, when femur rotates medially over stabilized tibia. Okay, unlocking. Done by popliteus muscle. Which mechanism by which it unlocks the knee joint by moving femur laterally over stabilized tibia. Okay. Physiological means Physiological locking caused by quadriceps femoris, last 30 degree of extension when femur rotates medially over stabilized tibia. Unlocking done by popliteus muscle, mechanism by which popliteus unlock the knee joint, moving femur laterally over stabilized tibia. Okay, pathological, locked in partial flexion, inability to extend the knee for the last few degree. In pathological, what happen during locking mechanism? There is inability to extend the knee for the last few degree, caused by causes, pathological causes by which locking occur. These are one mnemonic, fool me, fracture of tibial spine, osteochondral fracture, osteophytes fracture in osteoarthritis, loose body in the knee, meniscal tear. So in pathology, locking is of two types: physiological, pathological. Physiological caused by quadriceps femoris. What happens in this? Last 30 degree of extension when femur rotates medially over stabilized tibia. Locking done by popliteus muscle, moves femur laterally over stabilized tibia. Pathological, locked in partial flexion, inability to extend the knee for the last few degree, caused by causes of pathological locking. Mnemonic, fool me. Have for fracture of tibial spine, osteochondral fracture, osteophyte fracture in osteoarthritis, loose body in the knee, meniscal tear. Okay. Now, type of movement. Open chain movement, closed chain movement. Open chain movement, closed chain movement. Okay. In open chain movement, knee extension, from flexion with foot off the ground. In closed, knee extension from flexion with foot on the ground. External rotation of tibia occur. Here internal rotation of femur occur. Here tibial tuberosity moves toward lateral border of patella. Here center of patella to move medially, hence tibial tuberosity moves toward lateral border of patella. Movement, two type of movement are there: open chain movement, closed chain movement. Open chain movement, knee extension from flexion with foot off the ground. Foot off the ground, okay. External rotation of tibia occur. Tibial tuberosity moves toward lateral border of patella. In closed chain movement, knee extension from flexion with foot on the ground. No, foot off the ground, foot on the ground. Foot on the ground. Internal rotation of femur occur. Center of patella to move medially, hence tibial tuberosity moves towards lateral upper border of patella. Okay. It measures measurement and by 30-degree knee flexion to center patella in trochlea. Value: female have more value than male. Recurrent patella dislocation factor which causes recurrent patella dislocation. Factor causing recurrent patella dislocation are use power what, okay, hyperlaxity, obesity, underdeveloped lateral femoral condyle, genu valgum, external tibial torsion, patella too high or too low, weak medial ligament. Okay, classification. By the name of Smiley classification, given by Smiley. Here mnemonic: height, hemarthrosis, immediate swelling, delayed swelling, effusion. These two belong to different category. Hemarthrosis and immediate swelling belong to cruciate injury. And delayed swelling and effusion belongs to meniscal injury. Now we have discussed measurement, 30-degree knee flexion to center, patella in trochlea, value female have more value than male. Recurrent patella dislocation factors are huge power what, okay, H for hyperlaxity, underdeveloped lateral femoral condyle, genu valgum, external tibial torsion, patella too high or too low, weak medial ligament. Classification, Smiley classification. Hemarthrosis, immediate swelling is category of cruciate injury. Delayed swelling and effusion, meniscal injury, belongs to meniscal injury. Now symptoms and sign. First see the symptoms. Clip, I will give you so many mnemonics. Catching, locking, instability, popping, joint line pain, weakness. Okay, sign, pair sign, okay, test for functioning of meniscus, test for functioning of meniscus. It also have mnemonic. There are 5 tests. Tesla, Eags test, place test, grinding test, McMurray test, Steinman tenderness test. Okay, now talk about vascularity of meniscus. There are 2 views, at birth and at adult. At the birth, entire meniscus is vascular. Meniscus is vascular. In adult, 10 to 25% lateral meniscus is vascular. Lateral meniscus. In the 10 to 30% medial meniscus is vascular. Okay, so we have done symptoms, test and vascularity. Symptoms: clip jaw, catching, locking, instability, popping, joint line pain, weakness. Okay, pair signs are pair signs important. Okay, pair signs found. Okay, test teams, Thesle test, age test, Apple's grinding test, McMurray test, and Steinman tenderness test. Okay, vascularity, birth entire meniscus is vascular in adult, 10 to 25% little meniscus is vascular, and 10 to 30% middle meniscus is vascular. There are 3 zones. Three zones are found. One is red zone, which is highly vascular. Red white zone, which is lesser vascular than red zone, and then white zone, which is avascular. Okay. Treatment for meniscal injury is arthroscopy. Treatment of child. So we have covered the knee portion. Now come to the abdomen one. In abdomen, only one deformity is there, athletic pubelgia. Which is also known as sportsman hernia. Or Gilmore sign. Gilmore groin. This is our next. A simple picture I can show you. Our today's topic full of Olympics. Look at him. They mostly suffer from athletic pubelgia. These individuals. Okay. Now, in this chronic pain, in the inguinal or pubic region, athletes noted primarily on exertion. पैथोलॉजी देखें इसके क्या होता है. Site most commonly involved is insertion of rectus abdominis, rectus menis on the pubis primary side. Conjoint tendon insertion, adductor longus insertion. Clinical feature: pain following exercise, inguinal pubic region. In the inguinal or pubic region, and tenderness at pubic tubercle. Management for this may be conservative or surgical. Conservative, surgical when conservative fails. Okay, in conservative we mostly go with RIA, rest, ice, anti-inflammatory. In surgical, nasovix operation. Okay, so we finished the athletic pubelgia. In athletic pubelgia, chronic pain in the inguinal and pubic region in athletes that is noted primarily on exertion. Pathology: insertion rectus abdominis on the pubis primary side, conjoint tendon insertion, adductor longus insertion. These are the site. Secondary sites and clinical feature: pain following exercise, inguinal pubic region, tenderness at pubic tubercle. Management: conservative and surgical. Conservative we will go with RIA, rest, ice, anti-inflammatory, and surgical when conservative fails we will do surgery, and that names nasovix operation. Now we finish the abdominal region. Now come to the ankle. In ankle, first is ankle ligament injury. Classification for this: type 1, type 2, one sprain, type 2 sprain, type 3 sprain. Minor tear, incomplete ligamentous stretch, complete ligamentous stretch. Here important note is most common site for ligament injury in ankle joint is site of ligament injury ankle joint. In ankle joint, which ligament is most commonly torn? Anterior talofibular ligament. Most common mode by which ankle injury occur? Ankle injury inversion of plantar flexed foot. Treatment: price protection, rest, ice compression, elevation. Okay, second one is Achilles tendonitis. Second deformity is Achilles tendonitis. Okay, so we completed ankle ligament injury. In this classification, three type of sprains are there. Type 1 sprain, minor tear. Type 2 sprain, incomplete ligamentous stretch. And type 3 sprain, complete ligamentous stretch. And note, most common site for ligamentous injury is anterior ankle joint, or ligament is most common site for ligament injury is ankle joint. In this, which ligament is most commonly torn? Is anterior talofibular ligament. Okay, most common mode of ankle injury, inversion of plantar flexed foot. Okay, and treatment by the price: P for protection, R for rest, I for ice compression and elevation. Now come to the Achilles tendonitis. Difficult to treat. Difficult to treat. Of all tendonitis, Achilles tendonitis is most difficult to treat. Okay, arterial supply, to proximal part, at proximal part and distal part. In proximal, arterial branches at gastrocnemius soleus complex. Okay, at distal, small interosseous vessel at the insertion of the tendon. Okay, here a vascular zone is there on a water side zone, a vascular zone known as water side zone. Two to 6 centimeter proximal to Achilles tendon, insertion into the calcaneus. Avascular zone, waterside zone, 2 to 6 centimeter proximal to Achilles tendon, insertion into the calcaneus. Okay, and now see the tendonitis. Insertional, two types: insertional, non-insertional, non-insertional. Non-insertional is most common than insertional. Okay, now insertional at insertion site. It occurs at insertion site, associated with retrocalcanean bursitis and Haglund deformity. Cause: overuse. Cause of insertional tendonitis is overuse of tendon. It occurs at waterside area, side zone, mostly seen in runners and jumpers. Commonest site of tendon rupture. Okay, so see, Achilles tendonitis, difficult to treat of all tendonitis, and artery supplies at proximal part is at gastrocnemius soleus complex. Distal part, small interosseous vessel at the insertion of the tendon. Okay, avascular zone, waterside zone, 2 to 6 centimeter proximal to Achilles tendon, insertion into the calcaneus. Tendonitis, two types: insertional and non-insertional. Non-insertional is most common than insertional. Insertional at insertion site. Okay, insertion of tendon, associated with retrocalcaneus bursitis and Haglund deformity. Cause by which insertional tendonitis occurs is overuse of tendon. Okay, non-insertional tendon most common, and it occurs at waterside zone, mostly seen in runners and jumpers. Most important point. Mostly seen in runner and jumpers. Common site of tendon rupture. Okay. Now come to the third deformity, tendon rupture. More common in middle age and adult people. Cause by which it occurs: intrinsic weakness of tendon, which is due to repetitive microtrauma, or incomplete healing in waterside zone. Okay. It includes SAP, supraspinatus, Achilles, biceps. Okay. Mechanism of injury. Sudden plantar flexion. Of foot. More common. Unexpected dorsiflexion of plantar foot. Direct trauma, long standing, non insertional tendonitis. And this point and this point is most important. Test for testing the tendon. One mnemonic SOT, Simon's test, O'Brien test, O'Brien needle test, Thompson test. Okay. Treatment may be operative or non-operative. Operative or non-operative. But in non-operative there is a recurrence of tendonitis, tendon rupture is there. Non-operative, not so good result are there. Not so good result are found. Okay. Now come to the foot section. We have finished the tendon rupture, more common found in middle-aged and elderly people, cause intrinsic weakness and repetitive intrinsic weakness, which is due to repetitive microtrauma to tendon or incomplete healing in waterside zone. Includes these. This is more important. Supraspinatus, Achilles, biceps. Okay. There is pneumonia, that's why I am not highlighting this. Supraspinatus, Achilles and biceps. Mechanism: sudden plantar flexion of foot and an unexpected dorsiflexion of plantar flexed foot. Okay. Direct trauma, long standing, non-insertional tendonitis test, SOT, Simon's O'Brien needle test, Thompson test. Treatment may be operative or non-operative. Non-operative is not good. Good result are found. Not good result are found. There are now foot, hammer, toe. Only one pathology is there. It is plantar flexion. Deformity of proximal interphalangeal joint associated with hyperextension of metatarsophalangeal joint. Okay, enough. Now come to the hand. First is gamekeeper or skier's thumb. Most common injury: first metacarpophalangeal joint. Symptoms: pest, pain, ecchymosis, swelling, tenderness. Here these are present around the first metacarpophalangeal joint. Tenderness is diffuse in nature, present around the ulnar region. Okay. Anatomical pathology described by Steiner. They said adductor pathology, adductor aponeurosis, interposed between the ruptured ulnar collateral ligament and its site of insertion on the base of the proximal phalanx. Clinical examination: prominent lumbar form, pathological rotation of thumb. Pathological rotation of lump. Prominent lumbar form. Prominent lump is found, and pathological rotation of thumb is there. We can use MRI for diagnosis. Okay. It differentiates between incomplete and complete rupture. Okay. Treatment: braces 4 to 6 weeks के लिए. We can give braces for 4 to 6 weeks for complete rupture. We have to do surgery. Okay. So we complete the gamekeeper's skier's thumb. This is most common injury of first metacarpophalangeal joint. Symptoms: pain, ecchymosis, swelling, tenderness around the first metacarpophalangeal joint. Tenderness is diffusive type, diffusive in nature. Tenderness is of diffusive nature. Anatomical pathology: Steiner, which adductor aponeurosis interposed between the rupture and the collateral ligament at site insertion on the base of the proximal phalanx. Clinical examination: prominent lump pathology and MRI incomplete. Presses 4 to 6 weeks. Complete. Okay. Now come to the another pathology. Mallet's finger and baseball actually basketball finger. Okay, this is our last pathology. In this, avulsion of extensor tendon of the distal interphalangeal joint from its insertion at the base of distal phalanx. In Mallet's finger, there is avulsion of extensor tendon of the distal interphalangeal joint from its insertion at the base of distal phalanx, caused by direct trauma to the phalanx. Sign: swan neck sign at the fingertip. Okay. Treatment: splint, hyperextension, position for 6 to 8 weeks. If lesion become old lesions, there should be a tendon reconstruction. In normally, surgery is not indicated, but in old lesion there should be we can do tendon reconstruction. Okay. In children's, if Mallet's finger occur, we can diagnose with radiograph and treatment. For treatment, we provide splint for 3 to 4 weeks. So we finish Mallet's finger too. This is important topic. Mallet's finger and basketball finger. In this, avulsion of extensor tendon of the distal interphalangeal joint from its insertion at the base of the distal phalanx, cause direct trauma. Sign: swan neck sign at fingertip. Treatment: splint, hyperextension position. Kept the finger in hyperextension position for 6 to 8 weeks, and surgery is not indicated in acute lesions. For old lesions, tendon reconstruction we can do tendon reconstruction for old lesions. Now one important thing. Thank you. I'm signing out for today and meet you again in the next video.